All right, let's dive into diagnosing congenital vascular malformations, or CVMs. If you're a med student or a junior clinician, think of this as your practical, step-by-step guide for when you see one of these in the wild. Let's get right into it.
Okay, so picture this. You're on your pediatric rotation and a parent is pointing at a vascular birthmark on their brand new baby. They're worried, they want to know what's going on. Now, before you even think about ordering a single test, there is one question you have to ask yourself, and the answer will send you down one of two completely different paths.
So here's how we're going to tackle this. We're going to use what I like to call a diagnostic funnel. We'll start broad, asking, is it a CVM or the much more common infantile hemangioma? From there, we'll get more specific with the physical exam, we'll classify it by blood flow, pick the right imaging, and then finally, we'll put all the pieces together. Okay, so let's start at the very top of that funnel. Figuring out if you're dealing with a CVM or an infantile hemangioma is, without a doubt, the most important first step. And luckily, the answer is usually hiding in plain sight, right in the patient's history.
This table really breaks it down beautifully. Just look at the first two rows, presence and growth. A CVM is a structural mistake. It's there from birth, even if it's subtle, and it just gets bigger as the child gets bigger. An infantile hemangioma, on the other hand, is a benign tumor that pops up a few weeks after birth. It grows like crazy for a while, and then, and this is the T, it starts to shrink all by itself. So just asking about the timeline gives you a huge clue. Your history taking is your superpower here.
So once you're pretty sure you're on the CVM path, it's time to actually examine the patient. Your hands and your stethoscope are going to give you some major clues that help us get to that next crucial step, classifying the lesion.
Your exam is a really straightforward three-part process. First, just use your eyes. Look at it. Is one arm or leg bigger than the other? Then you palpate. Put your hands on it. Does it feel warmer than the surrounding skin? Can you feel a buzzing, like a little engine humming under your fingertips? We call that a thrill. And finally, you listen with your stethoscope. If you hear a whooshing sound, a bruit, that's a huge finding. A thrill and a bruit together are classic signs of a high-flow lesion. Lock those two away in your mind.
And that brings us to the main event, the central branching point in this whole diagnostic journey. Everything you've done so far, the history, the exam, it's all been leading up to this single critical decision. This is it. This is the big fork in the road. Is this thing high flow or low flow? Because honestly, the answer to that question changes everything that comes next. It dictates how worried you should be, what imaging you're going to order, and what the treatment might look like. Getting this right is absolutely crucial. Now, the system we all use for this is called the Hamburg classification. It's a way of organizing CVMs based on their blood flow, basically separating them into those two big buckets, low flow and high flow. This isn't just some academic thing. It's the clinical framework that's going to guide every single one of your next moves. And this just lays out the difference perfectly. On the left, you've got your low-flow lesions. Think veins, lymphatics, capillaries. They're usually soft, you can squish them, and you won't feel that buzz or hear that whoosh. But on the right, you've got the high-flow lesions. These are basically direct connections between arteries and veins. And that's why they're warm to the touch, and why you feel that thrill and hear that bruit you found on your exam. It all connects. Okay, so your clinical suspicion is strong. You think you know what you're dealing with. Now it's time to get some pictures to prove it. Imaging is how we confirm our hypotheses and really map out the anatomy of the lesion. So you don't just order everything at once. There is a logical flow. You'll almost always start with a duplex ultrasound. It's fast, it's easy, and it confirms if you're right about the high flow or low flow state. But for the really detailed anatomical picture, the undisputed gold standard is an MRI. And if you're dealing with a high-flow lesion that might need intervention, you'll eventually need an angiogram to get a perfect roadmap of all the blood vessels.
So why is MRI the king here? Well, specifically, it's the T2 weighted sequence. Here's the cool part. On a T2 scan, anything with a lot of fluid in it shows up as super bright white. And since these vascular malformations are basically just a tangle of fluid-filled channels, they light up like a Christmas tree. This gives you this incredibly clear picture of exactly how big it is and what it's touching.
And here is a perfect example of what I'm talking about. This is a T2 MRI of a patient's face. See that bright white blob in the right cheek? That's it. That's a low-flow venous malformation. You can see its borders so clearly. This is exactly the kind of math a surgeon or an interventional radiologist needs before they can do anything. All right, you've done it. You took a history. You did your exam. You ordered the right imaging. You've put the puzzle together and you have a diagnosis. But, and this is a big but, your job isn't over. In a way, it's just getting started. This is such a critical point. That vascular malformation you see on the skin, it could just be the tip of the iceberg. You always have to step back and ask yourself, could this be part of a bigger, named syndrome?
You start to learn the patterns. See a port wine stain on the face, you need to think about Sturge-Weber syndrome, which can mean seizures or glaucoma. See a big birthmark on a leg that also happens to be bigger than the other leg? That should scream Klippel-Trenaunay syndrome. And if that same overgrown leg also has the signs of a high-flow lesion, now you're thinking about Parkes-Weber syndrome. Recognizing these constellations is a huge part of the job.
And this brings us to maybe the single most important takeaway of this entire talk. These conditions are complicated, super complicated. No one person can manage them alone. The sources are crystal clear on this. Right from the get-go, the diagnosis and the workup have to be a team sport. So as you finalize that workup and you've confirmed the diagnosis, your final move isn't writing a prescription. It's picking up the phone. The real last step is asking yourself, who do I need to call? Who's on my team? Is it dermatology, surgery, interventional radiology, genetics? Building that team, that's what takes a good diagnosis and turns it into a great outcome for your patient.